Welcome to the Sports Docs Podcast. I'm Dr. Ashley Bassett.
And I'm Dr. Catherine Logan.
On each episode, we chat about the most recent developments in sports medicine and dissect through all the noise so you know which literature should actually impact your practice.
On today's episode, we're focusing on the thrower's shoulder with Dr. Sara Edwards, an orthopedic sports medicine and shoulder surgeon at UCSF. We have some great articles for you that contribute well to our conversation on different shoulder pathology in the overhead throwing athlete. As always, links to all of our papers that we discussed today on the show can be found on our podcast website, www.thesportsdocspod.com.
For many of us, being active isn't just about sport. It's about living fully. But when knee pain or ankle instability gets in the way, it can feel like your body is holding you back.
That's where push braces make a difference. The PushMed ankle brace AcquiFlex and the Push Sports knee brace provide the stability you need without locking you down. Sleek, comfortable, and crafted in Europe, they're built to move with you, whether that means training hard, going for a run, or simply staying strong and confident day to day.
With innovative designs that support while allowing natural movement, push braces help athletes and active people alike find relief, prevent pain, and stick with their treatment so they can keep momentum in their lives.
See the difference at bracelab.com. Clinicians can email samples at bracelab.com and mention the Sports Docs for a free sample.
Are you an early career orthopedic surgeon or fellow eager to expand your expertise? JRF Ortho has some exciting news. Starting early in 2026, JRF Ortho is launching a quarterly traveling fellowship program designed to provide you with hands-on exposure to osteochondral allografts, meniscus, and ligament repair, all in a dynamic and stimulating hands-on environment.
Each fellowship will be led by distinguished faculty with opportunities to learn in different regions across the U.S. Fellows will also get an exclusive behind-the-scenes look at tissue processing with tours at our partner facilities in Denver.
Every quarter, 3 outstanding candidates will be selected for this unique experience, and one of those quarters will be dedicated entirely to an all-female cohort, with both faculty and fellows coming together to advance women in orthopedic surgery.
Applications open this September for the winter program, which kicks off in January. Want to learn more? Reach out to marketing@jrfortho.org.
We start off our discussion today with a review article from the April 2023 issue of the Yellow Journal, titled Surgical Treatment of Superior Labral / Biceps Pathology in the Overhead Thrower. The authors concluded that type 2 slap tears are the most common and are often difficult to diagnose due to frequent false positives on MRI. Therefore, history and physical exam correlation are critical. Nonop management, including rest, physical therapy targeting internal rotation deficits, and correction of scapular dyskinesis can help, but return to play rates among pitchers remains low, around 22%.
When surgery is indicated, options include labral repair, biceps tenodesis, and rarely tenotomy. Slap repair yields variable outcomes, with elite throwers showing the poorest return to prior performance. It's often less than 40%. Biceps tenodesis was once a salvage procedure, but is now increasingly favored for selected athletes due to higher satisfaction, improved function, and return sport rates of 70 to 80%. However, its impact on elite throwing mechanics remains uncertain.
Then, from the June 2022 issue of JSES, we discuss a systematic review article titled Return to Play Following Non-Surgical Management of Slap Tears. This study evaluated outcomes of conservative treatment in 244 athletes, 162 of which were elite. Across 5 studies, the overall return to play rate was 54%, rising to 78% among those who completed rehab. Return to prior performance was 43% overall and 72% for rehab completers. Successful programs emphasized restoring internal rotation, correcting scapular dyskinesis, and strengthening the rotator cuff and kinetic chain, with most athletes returning within 6 months.
Risk factors for failure of conservative treatment were older age, overhead sports participation, particularly baseball pitchers, traumatic injury, positive compression rotation tests, rotator cuff pathology, longer careers or symptom duration, and Bennett spurs. Patient reported outcomes improved significantly with non operative care. The authors conclude that non surgical management can be effective, especially for athletes who adhere to structured rehabilitation, but success is less predictable in older or high demand overhead throwers.
We are joined today by Dr. Sara Edwards, an orthopedic sports medicine and shoulder specialist at the University of California in San Francisco and an associate professor at UCSF School of Medicine. She received her medical degree from Northwestern University and remained at Northwestern to complete her orthopedic surgery residency. Thereafter, she completed a fellowship in sports medicine and shoulder surgery at Columbia University. Dr. Edwards is currently the team physician for the City College of San Francisco, the University of San Francisco, and the Oakland Ballet. Welcome to the show, Sara. Thanks so much for taking time out of your very busy schedule to join us tonight for this discussion.
Thank you. Thanks for having me, guys.
Yeah, we're excited to have you.
Absolutely. So, as many, if you guys have listened to our episodes before, we've covered a lot of pathology regarding the shoulder over our many episodes. Had a couple episodes recently dedicated to the management of slap tears. We've had more episodes than I can count on rotator cuff injuries, but throwing athletes are a unique breed, and we haven't really dived specifically into that. So we do want to start there. So, Sara, can you briefly outline how shoulder pathologies in throwers differ than what we typically see in like non-throwing athletes or contact athletes? Like what kind of patterns of injury are you typically seeing in this population?
Yeah, thanks, Ashley. That's a great question. So, we definitely see a different gamut in the throwing athlete. You see, I think, more advanced injuries at a younger age. So you might start to see rotator cuff problems in these young people. And it really starts in adolescence, right? So you can see some pathologic changes when they're young. There's some thought that if they're throwing too much when they're young, that you'll see really some bony changes that occur. And then with time, you get this constellation of labral tears, you get GERD syndrome or glenohumeral internal rotation deficit. And then that puts pressure on the rotator cuffs. You start to see rotator cuff issues at a younger age. So kind of a whole spectrum of things that occur that are unique to throwers.
Yeah, for sure. And, we know that like MSK injuries can be impacted by adjacent joints. So the thing that people are always talking about is like, okay, you have an ACL injury, what's going on with like hip weakness, or are there foot and ankle issues going on that's like leading to that dynamic valgus? So, the shoulder, we think about that too. So Sara, like from your perspective, like how do you think about the kinetic chain and like the biomechanical stresses it places on the glenohumeral joint?
Yeah, no, all of that is important. And the more, it's funny because I still feel like research is being done and coming out, as we speak. So, a big thing in the last few years has been about hip rotation and stability and looking at their hip strength. And that seems to be related to how much pressure they put on the shoulder and elbow. And then their throwing mechanics are just something that's really been studied in orthopedics. So I feel like every meeting we go to, there's the picture of the throwing cycle. It's kind of showing, leg cocking. So you see these different positions. And so, we're learning as we go, like when they have pain in certain areas, what that means. So yeah, no, I think there's a lot of attention now being paid. And also, the scapula, just like scapular mechanics and how, so essentially like working from the hip, the spine, all the way up, scapular mechanics. The scapular mechanics seem to be quite important, right? So if they have hypermobile scapula or it's moving in an abnormal pattern, then that puts pressure on the shoulder and elbow as they throw.
Yeah, for sure.
So obviously there's a lot of biomechanical stresses imposed on the joint, like you just said, and there's different phases of the throwing cycle that can incur different stresses. So we'd like to segue to talking about slap tears and kind of how those different phases of the throwing cycle impact different mechanisms of slap tears. So can you discuss the difference between like a peel back mechanism and a traction mechanism, like when you're seeing those kind of injuries and how they kind of present, on imaging, but also clinically?
Yeah. So, the classic peel back, they'll feel it kind of in late cocking when their arm is back and retracted. So you get that pressure of so if you have GERD defect, right? Gluteohumeral internal rotation deficit, when the patient or when the thrower goes into late cocking. I'm trying to show you on my,
Yeah.
on this limited camera view, but you go into late cocking, and that makes you have tightness of the posterior capsule. And so then the capsule shifts posteriorly, and that causes pinching of the posterior cuff and labrum. And then as far as the traction, that's usually with release, as they throw, they'll feel pain, they feel this dead arm syndrome. But, constant throwing, particularly in pitchers that are throwing high pitch counts for many years, that traction where they're will cause a pull on the proximal bicep, and then that causes the labrum to tear over time. And then you sometimes get the baseball player who's diving into first base, and they get the classic like compression. It's more traumatic in that phase. So, but yes, the slap lesion is the bane of the baseball player's existence. Although maybe it's beneficial too, right? So you get this adaptive slap lesion. I kind of like that term. That's a term that's come out since I started training, where they realized that, some patients will develop that over time. It allows them to get more external rotation and then theoretically get more whip on the ball and be able to throw it harder and longer. So it's kind of interesting that it's an adaptation now, it's considered, and not necessarily pathologic.
I remember like so much has changed with slap tears. So when I was a therapist, everybody had a slap repair. It just like tenodesis was not a thing, or like, so it's interesting. Like we are continuously like learning about this pathology, and, I love that. And I think it makes it interesting. But I love your description. So thank you.
Yeah. It's kind of, I'm getting old enough now that like you look back at your career and you're like, wow, it has changed so much how we treated them. So when I finished my residency in 2005, and we fixed every slap. If they came in with shoulder pain, had a slap tear, they were getting surgery. And then when I did my fellowship, actually we did this kind of first study that looked, and what's great too is when you look back at those original papers, it's like a series of 17 patients that had a slap repair, and they all were doing great, so it's really interesting to look back at those initial papers by some of our giants in orthopedics, like Jimmy Andrews, Steve Snyder at SCOE, these amazing orthopedic guys. But, they would publish like an 8-patient series of pro athletes and be like, hey, they're doing all right. And like, that was kind of that became orthopedic dogma, right?
Yeah.
And when I was at Columbia for fellowship, we actually did the paper on non-operative treatment of SLAB, because my mentor, Ted Blaine, was like, they're not all doing that well.
Yeah.
Like,
No.
we're fixing all these. And, a lot of them do really poorly. And so we started kind of looking at different athletes and who was having surgery and who wasn't. And then we published on it. So it was kind of the first thing that showed, hey, not all these need surgery. And we ended up winning a big award at the sports at AOSSM for that year, which was exciting. But it was, and I remember when we started doing the paper, one of the attendings there, who's also one of my mentors, was like, this is stupid. Non-operative slap. Why are we doing this? No one wants to hear this.
It's so true how so much changes. And
yeah, like I have
go ahead.
I was just say I have a distinct memory of doing slap repairs in residency, and like that was like they were putting like the sutures around the biceps tendon, like around the biceps anchor, and now it's like we know not to do that. It's just very interesting how things have changed. Like, I mean, I guess I'm not young anymore, but like I still think of myself as like just out of residency, and I'm like, oh man, things have really changed. And so I think that's the cool thing about sports medicine, right? Like you're doing the same thing you were doing 10 years ago, like you're not doing the right thing probably, right? So like it's good to see historic data, but it's also good to like move forward and change, and that's what's really exciting about it.
So examination of that painful shoulder, though, with that throwing athlete, it's super involved. As you indicated, we have to think about the whole kinetic change and try and tease out, okay, what part of that, what's the pathology that we're worried about. But if we're specific to slap tears, Sarah, like what are your preferred diagnostic tests like on exam that you focus on to sort of help make your decision on where you're going?
Yeah, my go-tos, like when I'm actually focusing on the shoulder, I'll have them go through the range of motion, and I usually will have them, you make sure they take their shirt off or have a gown on so you can see their back. And I have them do a push up on the wall first, because I want to look at their scapula and how it's moving and make sure there's not winging. and look for atrophy, like in the infraspinatus fossa. See, because slaps can get that that little spinal glenoid notch cyst, right, and that can compress the nerve. So I look for that, and then I will palpate. My go-tos are really just palpating the bicipital groove. Very simple. I think the speeds test has been shown to be one of the most accurate. So I have them do a speeds test, just, full supination and elevation of the arm to see if they have pain at the bicipital groove. And then I really like the O'Brien's active compression test. So that's probably my go-to, where I'll kind of bring the arm across the body, test it at, 10 degrees of adduction, and then flip the thumb over and see, if it's painful down, painless up, it's a positive test. So those are really my go-tos to kind of identify SLAP. I'll check the rotation carefully. So I'm looking for that internal rotation deficit as well. And I do that. I'm pretty particular about that. I want them to lie flat on the bed, on the exam table, and I'll have them rotate so they're in that sleeper stretch position. So they're on their side, arms straight out in front, and then have them do forward motion. And it's amazing how many little subtle differences you'll pick up in these people that if they're standing, you can't really see it so well. But if they lie down and you lock that scapula down on the table, then you can really see it.
Yeah, absolutely.
Yeah. So following the exam, we are probably all going to get an MRI. Are you typically always getting an MR arthrogram if you suspect labral pathology, or does it depend? And how reliable do you find MR arthrogram or even MRI from distinguishing like true labrum tears and pathology from those adaptive changes that you were talking about, and even like normal labrum variants?
Yeah, so that's another thing that's evolved. So when I started in practice, we got an arthrogram on everybody, and now I get an arthrogram on nobody. Unless I'm looking for a UCL on the elbow, I still get it for that patient. But really, I think with the better MRIs, every MRI, I have access to 3 Tesla MRIs. Every patient I'm sending has a high quality MRI. And I do think that's a conversation with your radiologist wherever you're sending them, because it depends on how they trained and what they want. So, for example, when I worked at Northwestern, they wanted an arthrogram on everybody. If you suspected labral pathology, they were like, please get an arthrogram. Now out in California, they don't want it. They're like, no, we can see without it, and we prefer there not be one. They think it distorts the images a bit. So, and you're right. I think it's hard to determine, like, they're not perfectly accurate, so they quote anywhere from 92 to 97% accuracy, but I think they can be overread. I agree. They pick up a lot of particularly in a thrower, because they're all going to have changes, right? So
Yeah.
if they're a high level thrower, they're going to look abnormal. So, so I kind of take it with a grain of salt. In a way, it's more based on I still get it to confirm it, but I'm expecting there to be labral pathology. And then the question is, can you throw or not? Like, can you play through it? Because I try really hard to not operate on anyone in a thrower for the shoulder now. And so we try all the non-operative things first.
Yeah.
So
Yeah, that is a perfect segue.
Yeah.
Did I answer my next question?
Yes.
No, you're
You
actually
led
not doing that. Sometimes we do have
Yeah.
guests that like answer and they're like, oh, I just saw your question, didn't I? I'm like, yes, you did. Don't do that.
You led right into so our first paper looked at the rate of return to play following non-operative treatment of slap tears. And it looked at like what are the risk factors for failure of non-op. So Sarah, like, are you you're starting with non-op, it sounds like, for your slap tears. But like, tell us a little bit more about like how that tear type impacts your decision making. Like, is there anybody that you're like right away, there's just no chance, or that you counsel differently? Like, I'm more worried about you.
Yeah, no, I definitely think if they have like a type 3 with a bucket handle slap that's getting incarcerated, those are someone I would push to do faster. And in those, I generally just debride it, right? I would take that piece out. So there are slaps that you want to get to faster. I worry when it's extended up into the bicep. I worry if they have combined gross instability, like if they happen to have a dislocation and a slap, those tend to be a little bit worse. But the classic thrower usually has a type 2 slap, right? Just where it's lifted off, the bicep anchor's intact-ish. I mean, it's lifted off, but not split up into the tendon. And so for those, I'm more conservative for sure.
So Obviously, we're all attempting pretty significant conservative treatment, but people are going to go on to fail that and require surgery. So we want to talk a little bit about that. So our second paper is a Yellow Journal review article, and it highlighted that there's been a shift from traditional slap repairs in overhead throwing athletes towards biceps tenodesis. Though the authors did acknowledge that data on outcomes following biceps tenodesis, particularly in elite athletes, is quite limited at this time. So how are you approaching this decision making, particularly as we're seeing slap pathology in younger individuals? Like, personal story on my part before I let you answer, like, I'm having like high school athletes come in and like they're educated. Like, those parents, they're reading everything and they're coming in saying, slap repairs, stiffness, concerns with getting back, I want a biceps tenodesis. And I'm like, you're like 15 years old. Like, I don't feel like I can do that. And I feel like I'm kind of having this battle. How do you navigate that decision making, particularly as these kids are getting younger and younger with this pathology?
Yeah, it's a real actually it's a really big problem, as we know. And you know, I think what paper was really interesting was at a Rush several years ago, Tony Romeo
Mhm.
wrote, he was worried about the subtle instability when you do take the bicep. So that's the concern, is that if you don't fix it, then are we setting them up to get premature arthritis? And we don't really know. But they didn't have great results in returning him, even with the bicep tenodesis,
Mhm.
in those high level guys. So, but I have shifted my practice to being much more aggressive about bicep tenodesis. It's interesting. I had clinic all day, and the last patient I saw, we had this discussion, but he was easy because he was 50.
Yeah.
It's a lot easier when I'm 50. I will say the youngest bicep I've done was 19.
Mhm.
I did a bicep tenodesis on a 19-year-old who was a highly competitive swimmer, a butterflyer. It was an Olympic year. He wanted to go to the trials and he was unable to make his rotation. And I talked to him at length. Like, we tried the injections. He couldn't do his stroke. And so did the bicep tenodesis on him. And of course I'm worried, he's a swimmer, he's used to being loose, but I thought if I tighten him up, he's going to be miserable.
Mhm.
And he did beautifully, and he made the team, so that, 19-year-old, I
Amazing.
should probably write
Yeah.
that case up,
Yeah,
because it
Yes.
is the data, right? Like, here's a 19-year-old swimmer that was at a very, very elite level who had the bicep and ended up being able to get back quickly and train. So that was important. And I think in throwers, we don't know yet. I think you're right, exactly what you said. Like, but I am doing it younger and younger, and
Mhm.
for those reasons. I've not done a 15-year-old.
Yes.
And I think the oldest one I've fixed recently was 24, a 24-year-old. He was a lacrosse player who was like, doing this all the time.
Mhm.
And he had some combined instability as well. So he'd had a fall, he'd had a dislocation, and then he also had this big slap and was feeling it. And I did a full kind of instability repair all the way up. And again, in that case, I wanted to tighten him up a little bit. So his exam under anesthesia, he had full, instability on the table. So I think I'm tailoring it to the patient, right?
Yeah.
And
Yeah.
he
And
had
I think
time, but I think, again, I'm doing in my practice a lot more bicep tenodesis. Anyone over 30 now is really getting a
Mhm.
tenodesis and not a slap repair. Um,
same. And
yeah,
I think, you brought up the lacrosse player, and that's like a contact injury too. So like
yeah,
you're thinking a little bit more about their stability, especially if they did have a dislocation subluxation. So
Yeah.
like you said, I think it's, you have to be so specific, and it sounds like you're having really long discussions with people, which you just have to.
Yeah.
yeah.
Um,
And I think you
Even
brought up
today,
yeah.
oh, please go
No,
ahead.
no,
But
you're good.
yeah, my patient today was like this 50-year-old guy who came in, but he looked like Arnold Schwarzenegger. Like, he was super fit, and he lifts weights all the time. He's like, I lift weights 4 hours a day. I could tell this man was like incredible. And I was like, okay. And then, he sees himself as, a 25-year-old. He looks like
Mhm.
a 25-year-old.
Yeah.
He was in great shape. And he said, I want to, get back to everything. And he wanted a labral repair, but he was older. And I was like, he I clearly think a bicep tenodesis is the right move in him. And you
yeah.
could see the slap on his MRI. Like, you could see this, tear up into his bicep tendon. So I had the same talk with him. I actually pulled up one of the old papers and was showing him the research
Mhm.
and showing the West Point studies, that Brett Owens did about all the, this getting the soldiers back. And he was an ex-military guy. And he was like, oh, okay, this is the way to go.
Yeah.
But he came in thinking he was getting a labral repair. So,
What did he have a reason? Did he think there was like a contour or like, I was just curious.
no, he just didn't know, and he's like, "Oh, my labrum's torn. I need it fixed." And, I'm like, but he was 50,
Yeah.
Yeah.
I
Well, go ahead,
Oh no, I was just
Ashley.
gonna say, I think you really highlighted an important point about treating like the patient, right? Because a slap tear, like across like 5 different athletes, can be different. Like Catherine, you deal with a lot of lacrosse. I deal with a lot of gymnastics. And I feel like the ones that have actually done well with slap repairs, like in my hands, are like they almost like are hypermobility and have a slap tear that fails conservative treatment. And like if anything, it kind of tightens up the shoulder a little bit and they do better afterwards because they were having that
Right.
hypermobility despite all that PT, 6 months of PT. Versus like in a thrower, especially males, like they tend to be stiff at a baseline. So it's like then if you tighten them up at all, like they're really, really miserable. So I feel like that swimmer, that you reference is like a, good example, although, he really needs that motion. But like, I think it's different. Swimmer, thrower, gymnast, lacrosse, like you got to tailor it to the person and not just do the same thing in everyone.
Totally agree with you, because they're all a little different.
Yeah.
So,
All right. So Sarah, say we are doing a repair.
yes.
As far as like your intraoperative considerations, doing a slap repair, like how do you optimize the outcomes? Like as far as like your anchor placement or tensioning or, making sure like you over tighten, like how do you think through that? Like if you could share your wisdom there.
Yeah, that's a great question, Catherine. I think the one thing I try to not over tighten them. Okay. So that's lesson number one is just not getting too close to the bicep. I really try to stay off the bicep.
Mm.
And again, I think we were talking a little bit earlier, but in the past, like we would drop an anchor right at the top.
Yeah.
Sometimes you'd have two sutures in that anchor, and one would go in one side and one the other. And I'm so careful just to stay away. And then I'm also just kind of looking for underlying other pathologies that might be going on. If there's a little cuff fraying, I might debride that. Usually that's probably not the source of pain, but I just try to look around the shoulder. But I'm really looking for other instability. And if anything, I see more commonly with slaps, like combined posterior instability. They'll have some subtle, so I do a good exam under anesthesia. That's step one. I think when I'm putting my portals in, I make a lot of care to put that posterior portal very, very lateral. So I have a nice angle coming at the posterior labrum. And then I also try to, again, stay away from the bicep. That's one of my keys. And then I also like the Port of Wilmington portal, which is I don't use very much at all, except if I'm doing a slap repair, which is like a centimeter off the back of the chromium, 1 centimeter over. And then I isolate with a spinal needle, and I like to percutaneously drop anchors in through that. And again, I used to use a suture tack, which was, a solid anchor. Now I'm using all suture. When I'm up top, I like the knotless anchors. I do like to tie knots still on the bottom. If I'm doing instability work or bank hurt work and I'm trying to really tighten them, I like to feel that knot go down. But when I'm up doing a slap, I'll do the knotless ones.
Yeah. Those perk kits are nice too,
Yeah.
Yeah,
as far
they're
as
great.
like how that's advanced. That was how Ashley, I don't know if you remember, we trained at the same place. So it
Yeah.
was like Holovacs used to do it the same
Yes.
way. I don't know
Yeah.
if you did that, but
Mm-hmm.
yeah,
Oh,
I
definitely.
enjoyed that technique.
Yeah, the perk kit was a game changer for me because you can
Yeah.
just feed it in and like drop the needle in. It's such a wonderful like tool to
Yeah.
have all that big needle that you can thread the nitinol wire through and then put the dilator in. It's really nice.
Yeah.
Yeah. Things
But
we
yeah,
need to think of
Yeah.
and
yeah, I
invent
don't fix the
ourselves.
posterior cuff. Do you guys fix the posterior cuff on your way out? Because I don't.
Yeah.
Yeah, I don't either.
No. Yeah.
Yeah, I don't either.
Yeah, the perk kits have been great because you can put it exactly where you want. You don't have to worry about like getting the curved guides or whatever. You can just exactly where you want to put it. And you don't have to compromise. So it's
Right.
really come a long way. So obviously one of the concerns that we've been talking about is stiffness, right? That's the reason why my 15-year-old and his parents don't want to have the slap repair. They think he's not going to
Yeah.
be able to pitch in college. So stiffness is a major concern. Sarah, how are you addressing that after surgery? You talked about intraoperatively, like things you're doing to avoid that stiffness, but postoperatively, like what does the rehab look like? And if you sense someone's getting stiff, what are some things that you do to intervene and try to counteract that?
Yeah, I used to be really strict about leaving patients in a sling for 4 weeks, and now I get them moving a little bit faster. If I'm doing a slap repair, I will have them start pendulums and shrugs and scapular retraction right away. And then I like them to actually see their therapist around week 2 to start some passive range of motion. I think it's safe to let them go up to about 120 and just get them moving so they don't lock down so hard. They still tend to though, so you have to be careful, and It's where I think having a good therapist kind of versed in this is really important. I really like, having them do sleeper stretches, I think is really good, just so they don't get that posterior capsular tightness.
Definitely.
Yeah, I think you hit the nail on the head with like the right therapist too, where it's like having that discussion of, just there's going to be people who are great with throwers or have a lot of knowledge and know to pick up the phone and call you and say, hey, this is not, going as we'd expect. Or, they're just like, they know how to tailor it and know what's okay and what's not okay. And it's like, you have to emphasize to the patient, nope, you need to drive farther and go to this therapist
Yeah.
because it's just so important, than going to somebody who's like, I never really do these, but we'll figure it out,
Yeah. Absolutely. Yeah. You want someone, it's kind of nice too, because once you're in an area for a while, you kind of learn the people that really like throwing athletes. And then, it's nice to, I'd say for the young surgeons out there listening, like find those people, and then make sure. And if you call clinics, they'll often say, oh, Terry really likes to do our throwing athletes, so there's usually someone in there that really embraces it. So,
Yeah,
Absolutely.
absolutely.
and then certain places, I mean, we're lucky at UCSF, we have like a throwing center, at the Children's Hospital. So that's really wonderful to have access to. Those therapists, I mean, their therapists and trainers are just dialed in, and they've got, motion analysis. We have all the bells and whistles, but that's not common everywhere.
Yeah, it's great. It's funny, like, and I think Ashley and I always talk about like the regional sort of differences. Like, there's not a ton of baseball, like at least in Denver. It exists, like, but it's not like a huge thing. But we get a ton of climbers. You know what I mean?
Oh,
So
yeah.
they're like, so it's just interesting. Like, it's a whole nother breed of the same sort of like, they just want to get back and they have their things that they want to do and they don't want to be stiff and they don't want, so it's interesting, like regionally how you get impacted.
All right. So we'd like to wrap up part one with a quick discussion on return to play. We always do this. We're talking about these sports related injuries. So, Sarah, when are you typically clearing patients to return to throwing after a slap repair versus tenodesis? Like, how does that differ? And how do you determine that they're safe to get back into that?
Yeah, Ashley, that's a great question, because that's why everybody wants the bicep tenodesis, because they do get back faster. So normally in a thrower, if I do a slap repair, it's going to be 9 to 10 months, mainly based on stiffness. And again, if they try to throw and their mechanics are off, they are going to cause more damage. So you have to be really, really cautious with them. One thing I learned from one of my mentors in Chicago, which was so valuable, was just really, again, I talk about checking their internal rotation with them on their side with scapula locked down on the table. And our rule, and this was the Cubs team doctor, okay, so he dealt with MLB patients all the time. And, if the rotation, so you check it, and they're going to be different. A thrower, we know they have excessive external rotation, they have limited internal rotation, not pathologically, it's just part of their anatomy from throwing for years. But if they were more than 20 degrees on the throwing side, if their internal rotation deficit was more than 20 degrees from the contralateral side, they were not allowed to throw. So we would make sure they would do that sleeper stretch to get within 20 degrees. And the shoulder surgeries in the Cubs organization over those few years went to 0. So so the trainers were trained to like watch them and then check their sleeper every day. And if they weren't within 20 degrees of the other side, their non-throwing side, then they were like held that day.
Wow.
So I taught that to like the people at Cal, and like as I've gone through my career, I'm like, hey, make sure they're within 20 degrees. And it seems to really, really help. Because again, having a measure, and that gives the athletic trainers that are helping the team, something to look for. It also gives the athlete a goal, because you teach them how to do it. And they're like, hey, you're not going to throw unless you, and they trust me, they will start stretching all the time. So they get within that range. So that's one big caveat I do, I guess, is making sure that rotation is good. And that's for non-operative treatment of slabs as well as operative. For bicep tenodesis, I let them get back usually within 3 months, so they can get back pretty quickly.
Nice.
Once they normalize, their strength gets back. And then I always do a progression, like a return to throwing progression, have them work with someone. So they start with just long tossing and then, work up to throwing off the mound. But you want to kind of follow those guidelines for return to throwing. And I follow the Andrews Clinic. Jimmy Andrews. I think it's Kevin Wilk is the PT who's written so much great data and so many good guidelines. And I use his guidelines, for returning my guys. So.
Thank you for listening to this episode of the Sports Docs. We hope you enjoyed the first part of our discussion as much as we did. On the next episode, we'll continue our conversation with Dr. Sara Edwards and shift our focus to rotator cuff pathology in the throwing athlete. Make sure to subscribe on Apple Podcasts, Spotify, Amazon Music, and YouTube to stay up to date on all things sports medicine. If you like what you hear, please consider leaving us a review or comment. You can also reach us by email at thesportsdocspod@gmail.com or find us on Instagram at thesportsdocspod. We love your feedback.